name is Andrea Cardoso. I'm research at the Microintelligence Center from Federal University of Rio de Janeiro from Brazil. And I will show you some of our results about vitamin A and body deposits. So, obesity is a universal disease of rising prevalence, which has been acquiring epidemic proportions. It reaches approximately 500 million people in the world, and in Brazil, it reaches approximately 15%. Obesity is multifactorial and results from complex interactions between genetic and psychological factors, cultural and environmental factors, lifestyle, and eating habits, consolidating a great paradox. We can imagine, if a person has excess food intake, it's expected that these individuals are nourished. But in most cases, these individuals are malnourished, showing a series of nutritional deficiencies, as we can see in some studies that evaluated dietary intake, as for example, Pinheiro. According to Pinheiro, there are a lot of micronutrients below the recommended amounts according to the dietary reference intakes, such as vitamin A. Vitamin A deficiency is one of the most prevalent public health issues in the world, being more severe in developing countries, resulting damage to the health of individuals affected by it, including night blindness, until blindness, and even death. So, recent studies demonstrate an important role of vitamin A and metabolic steroids and the regulation of body fat, demonstrating that the vitamin A is closely related with obesity. So, the connection between diet and biohomeostasis becomes increasingly understood. Scientific evidence demonstrates advances beyond the traditional nutritional functions, since some nutrients in food can alter gene expression and functions in cells. Vitamin A affects at least two processes related to energy balance, through adaptive thermogenesis and development and adipose tissue metabolism. About adaptive thermogenesis, the urinic acid has great influence on adipose tissues, which is the main site of thermogenesis. The urinic acid stimulates transcription of UCP1 protein, which is specific for adipocytes and regulates the energy reserves. It's believed that the urinic acid reduces adiposity, that correlates with a potential of adipose lipogenic depression with reduced levels of receptors PPAR. There are protein linked to modulation of gene transcription regulatory metabolism of lipids and glucose. The urinic acid has been recognized as a potent inhibitor of adipocyte differentiation. Besides, it promotes apoptosis of pre-adipocytes. In the same line, the adipose tissues plays an important role in homeostasis and metabolism of urinoids. It can absorb it, stock it, convert it, and mobilize the urinal store to attend local and total body demands. Apart from the role of the vitamin A and the metabolic steroids and the regulation of body fat, has recently received attention due to its action against free radicals. So vitamin A, due to its action, its antioxidant power, can prevent the occurrence of non-transmissible chronic diseases, such as obesity and related comorbidities. Comorbidities related to obesity, such as glycemias and dyslipidemias, tend to increase lipid peroxides, which in turn reduces cell antioxidant levels, among them vitamin A. In other words, vitamin A, besides participation in several primordial functions in the human organisms, such as immune system and gut, it may be associated with body adiposity. Furthermore, excess weight can lead to development of non-transmissible chronic diseases. Additionally, vitamin A can fight against free radicals protecting the body against oxidative stress associated with obesity and related comorbidities. In short, in obesity, especially by presence of comorbidities and production of inflammatory cytokines, there is an increased demand for antioxidant nutrients. So, this inflammatory process that is characteristic of obesity causes increased oxidative stress, which in turn reduces serum antioxidant levels, among them vitamin A, which is involved in metabolic status and the regulation of body fat. Furthermore, vitamin A deficiency can increase recruitment of pre-adipocytes and adipocytes, can inhibit apoptosis of pre-adipocytes, and can decrease adaptive thermogenesis. So, a great metabolic cycle was formed here, where obesity can lead to development of vitamin A deficiency, and vitamin A deficiency can rise this obesity, can worsen this obesity. So, in this context, where vitamin A is inserted in obesity, the micronutrient research group decided to study this micronutrient in obese individuals. There is a not classic risk group for vitamin A deficiency, but it deserves attention due to its increasing prevalence and related to comorbidities. Now I will show you some of our studies published in the last years. So this study, published in 2009, evaluated the relationship. The relationship with the nutritional status of vitamin A and pre- and post-operative gastric bypass. 114 patients were evaluated, and the prevalence of vitamin A deficiency was found in 14% in the pre-operative and around 49% and 39% in post-operative, with 30 days and 108 days after surgery. And a negative correlation between body mass index with renal and beta-carotene in pre-operative period was found. Yeah. So, with these results, concluded that with this study, it suggests that
they're trying to figure it out. So that's as good as we can get.
Okay. It suggests that the oral intake supplementation with 5,000 international units with retinol acetate does not present the expected impact, and the need of assess the nutritional status of vitamin A before and after surgery is emphasized. And the high prevalence of vitamin A deficiency and pre-operative days being more severe in post-operative days corroborates utilization of the cutoff of below 1.05 micromole per liter as a vitamin A deficiency marker in these individuals, and reinforce its utilization as a tool in a clinical practice to identify vitamin A deficiency in obese individuals. So, this is a more recent study and evaluating the cell levels and liver store of retinol and their association with night blindness in individuals with class 3 obesity. The night blindness prevalence was found in approximately 24%. And the serum levels and retinol liver store inadequacy were 14% and 8% respectively. And the association between vitamin A deficiency and night blindness presence was observed with both biochemical indicator and retinol liver store. And the vitamin A deficiency highest index occurred in patients with the highest body mass index. And distribution of night blindness prevalence was around 6% according to Sarah Reginald. Concluded that the vitamin A deficiency and the night blindness prevalence was high in class 3 obese individuals, and the functional indicator for night blindness diagnosis may be a promising marker for diagnosis in these groups. So, from these studies, we decided to study vitamin A in other obesity classes. So I will show you our preliminary results about this study entitled Vitamin A Deficiency is Associated with Body Adiposity in Women. So the objective of this study was investigating the nutritional status of vitamin A through biochemical and functional indicators and the association with body adiposity in women with recommended dietary intake of vitamin E. The inclusion criteria were women served by the nutritional service of Rio de Janeiro, adults at 20 years old or more, and all participants signed the consent form. The exclusion criteria were disabsorptive syndromes, acute and chronic infections, liver and kidney disease, diabetes mellitus, cardiac or respiratory failure, cancer, alcoholism, AIDS, pregnant women, nursing mothers, or use of medication or supplements containing vitamin E in the last 6 months. The components of the sample were chosen at random by collecting the first 5 other records of patients in the clinic, collecting 3 weekly, alternating days of the week. The sample size was 200 women, divided according to the body mass index, and the control group was formed by 8 eutrophic women, and the other groups was formed 40 patients in each. About the analysis of the variables, the retinol and beta-carotene were evaluated using high-performance liquid chromatography. The night blindness were evaluated by questionnaire validated by World Health Organization and Pan American Health Organization. And the dietary vitamin A were evaluated by 3-day food record, having a score of 700 microgram, is the same recommended by the Institute of Medicine. In statistical analysis were used these tests. It's our preliminary results, and this table we can see the cell concentrations and the presentation of inhabitants of retinol and beta-carotene in the groups. And we can see the retinol concentrations decreased expressly as high body mass index, and we can see the same behavior to beta-carotene concentrations. And we can see here the presentation of inadequacy and eutrophic group to retinol concentration was 7.5% and reached 22.5% in the class 2 obesity group. And to beta-carotene concentrations, we can see in the eutrophic group the presentation of inadequacy was 8.8% and reached 27.5%. When we compare in the groups, we can see there was a statistically significant difference between eutrophic group and all other groups to retinol concentrations. And we can see the same behavior to beta-carotene concentrations. And we can see there was a statistically significant difference between overweight group and class 2 obesity group to retinol concentrations, and between overweight and class 1 and class 2 obesity group to beta-carotene concentrations. A correlation between retinol and beta-carotene was found in all groups, and this correlation increases as high body mass index, demonstrate that is a relationship between retinol and beta-carotene. In addition to that, the high inadequacy of beta-carotene shown before probably occurred because the beta-carotene bioconversion to retinol, probably because the high oxidative stress and the high antioxidant nutrients, the demand. So beta-carotene keeps the adequate nutritional status of retinol. Here, when we evaluated the presence of night blindness, we can notice the night blindness increased at high body mass index from 0% in eutrophic group until 20% in the class 2 obesity group. This result was similar to that found in classic groups of risk in Brazil and in other regions considered endemic and biological moments of extreme nutritional demand. When we compare the groups according to the presence of night blindness, we can see there was a statistically significant difference between eutrophic group and all other groups, and between overweight group and class 2 obesity group. And our conclusion is inadequate nutritional status of vitamin A was associated with body adiposity, demonstrating that this seems to represent a major cause of depletion of this nutrient and can be considered an aggravation factor of vitamin A deficiency. Finally, the recommended intake of vitamin A cannot be strict because the demand is different for each individual. For example, a neutrophic individual demands different than obese individual because the metabolic status, the inflammatory process, the comorbidities. The comorbidities is worse as high body mass index. So we can't think only macronutrients, but also of micronutrients in these individuals. So, take into consideration the collective dimension of vitamin A deficiency reflects in aggravation of comorbidities related to obesity and having the present studies as basis. The precocious identification of individuals at risk or with deficiency of vitamin A is essential. Thus, the investigation of the nutritional status of vitamin A individuals with obesity can foment intervention strategies easily incorporated in the routine procedures already established, objectifying the eradication or at least the reduction of vitamin A deficiency rate and consequently reflect upon these individuals' quality of life. For example, the strategies easy is interview of night blindness, and we can, during anamnesis, we can evaluate more expanded points like smoking, sedentarism. These points high oxidative stress. So we need to think about it, adjusting recommendations, trying new protocols. We need to think about micronutrients in this great metabolic cycle that is obesity. And that's it. Thank you very much. It's my mail. It will be a pleasure if you contact me for any proposal. Feel free to contact me. Thank you.
Okay, time for the question.
Did you ever look at the dietary intake of their vitamin A? Do you have any idea what their vitamin A level is through their diet? Because the diet, did you ever?
The 3-day food record.
Right.
Yeah, if you how we did.
Okay.
Yeah, the person fill out 2 days on weekend and 1 day 1 weekend because
Okay.
weekend is change the
Right.
yeah
Right.
the nutrition, the environment about food. Yeah, there are it's a limitation about the evaluated dietary take. All presents limitation, but the 3-day food record is the more focused.
Okay.
Yeah, it's more utilized and then more utilization.
Acceptable.
Yeah.
Dr. Matos, I have one more question. With the vitamin A supplementation, can you see all of the eye dysfunction in obesity?
I think it's supplementation.
So all those kind of eye problems due to the vitamin A deficiency, right? So with the supplementation of the vitamin A, all those the dysfunction would be reversed in obesity?
No, we don't use supplementation. Yes.
So what do you think?
But I think more studies are needed, but we can't think about it because we can evaluate the vitamin A and the blood sample, it's perfect. But a lot of times we can't do it. So, and in fact, we are evaluating electroretinography. It's a gold standard for night blindness because the interview of night blindness isn't a gold standard. It's easy, it's fast, but it's not a gold standard. The gold standard is electroretinography. And now we are evaluating, compare both. And probably, I hope so, I will bring these results validating the interview of night blindness. And this way, we can evaluate the vitamin A deficiency and in future, supplementation. We need to evaluate better.
Okay, thank you. Actually, this certification has been shown to given to the speakers. Thank you, Dr. Matos, for the presentation. Dr. Clark, can you come here, please, for your